email. And our presenter for today's webinar is Dr. David Gelt. David B. Gelt is a South Jersey native. He is the Assistant Director of Sports Medicine and Director of the Sports Concussion Program at Cooper Bone and Joint Institute. He educates and mentors medical students as an Associate Professor of Cooper Medical School of Rowan University and an Associate Professor of Rowan University School of Osteopathic Medicine. He received his fellowship training in primary care sports medicine at the University Hospitals Health System in Cleveland, Ohio. He completed his residency in family medicine at UMDNJ SOM Lady of Lourdes Medical Center. He received his medical degree from UMDNJ SOM newly named Rowan Virtua School of Osteopathic Medicine and is board certified in family medicine and sports medicine. Dr. Gelt specializes in medical orthopedics, sports medicine, regenerative medicine using ultrasound-guided procedures, and concussion management. He strives to provide accurate diagnoses and takes pride in suggesting preventive strategies to ensure injuries do not reoccur. Dr. Gelt lectures nationally and regionally on various sports medicine topics. He has both authored publications in peer-reviewed journals and has contributed to sports medicine textbooks. He serves as team physician for Rowan University, Rutgers University Camden, and various high schools throughout southern New Jersey. He has served as a team physician for the Philadelphia Wings professional indoor lacrosse team, and he had the opportunity to be a team physician for USA Olympics at the Olympic Training Facility in Colorado Springs, Colorado. Dr. Gelt is an active member of the American Osteopathic Academy of Sports Medicine, American Medical Society for Sports Medicine, and American Osteopathic Association, as well as various state and local medical societies. He currently serves on the Board of Trustees and the Sports Concussion Committee for the Brain Injury Alliance of New Jersey. He has been named Top Doc and Top Doc for Kids in Sports Medicine in numerous publications, including Philadelphia Magazine, South Jersey Magazine, and South Jersey magazine, SJ Magazine, on a yearly basis since 2010. He is an avid runner who participates in multiple road races each year. Dr. Gelt resides in Voorhees, New Jersey, with his wife, son, and daughter. I am pleased to welcome Dr. Gelt.
Thank you very much. I appreciate that long introduction. You can shorten it next time, but I appreciate that. Let me just share my slides, if you don't mind. Guys see that okay?
We're not currently seeing it.
Hold on a second. How about now? Is that good?
Yes, yep, perfect.
Okay, sorry about that. Always technical difficulties. But I appreciate the introduction. Thanks for having me. I'm glad there's a lot of athletic trainers on the talk today, and I hope you guys get some introduction about it, updates as far as with the concussion evaluation management. We've had some increases with changes as far as return to play, which we're going to get into. But I really appreciate it. And again, make sure that you guys fill out your evaluation so you can get some CEUs. I know you guys need to have concussion CEUs every year, so hopefully this will help you guys. So concussion, especially Brain Injury Alliance in New Jersey has done a great service over the years since I've been on the board back in 2005, 2006, where we've really put this as a paramount importance with concussion, especially with sports and kids. So Brain Injury Alliance has done a great job. If you ever go to the Brain Injury Alliance in Jersey website, there's lots of pamphlets or handouts that you can give to your students, athletes, parents, and coaches. So it's often free. So you can also get that and make sure you have that so you can give them out to people for education. Unfortunately, concussion itself is not something where it's one size fits all. You can't just give an antibiotic in 5 days, you're going to get better. It's different for each person, depends on where you got hit, how you got hit, kind of symptoms you have, if they have any pre-existing conditions. So it's something that you have to individualize for each patient, depending on what their symptoms are. So Fortunately, it's not that easy to just say, okay, you're going to be better in 1 week, and then we'll have you go back to playing. Each person's different, and you have to take that into account. So today, objective-wise, we're going to update you on the 6th International Conference with concussion sport. This is ongoing since 2001. It was a little delayed because of COVID, but the last one was in Amsterdam in 2022. And it breaks down into updates as far as all the updated literature, and makes more of a consensus statement. We try to do this every 5 or 6 years. For the athletic trainers, if you haven't read it, there's also in the Journal of Athletic Training, there's a bridging statement from your last consensus about a decade ago that sort of mirrors what the Concussion Sport Symposium talked about. So if you haven't read that too, it's in the Journal of Athletic Training, I think in March of 2024. So it's also a good reference for you guys to have. We're going to talk about the evaluation and management of concussion and updates for that. Return to learn, which has been a high priority. Before, when it first started, it was just return to play, but now we're also finding that return to learn is just as important, or if not more important. And then we'll also discuss about recent research and things that are up and going for the future conferences. So what's the scope of the problem? If you, depending on what literature, what research you read, if you extrapolate about anywhere from 3 to 4 million people sustain a TBI annually, and the majority of those are concussions or mild traumatic brain injury. What we're going to talk about today is really the sports concussions. And that's usually involving the kids in organized sports from adolescent through college. The good thing with the last concussion symposium in Amsterdam, they also did bring about the research and updates for kids ages 5 to 12, because there was a dearth of literature with that. So they are trying to really put importance on the younger population as well. What's interesting is that even from 2001 2009, there was increased emergency department visits on concussion, and that may be just one also because of education. Since 2001, when the first symposium started, we've really done a good service of trying to educate people, whether it be ER docs, family physicians, athletic trainers, coaches, parents. So they're sort of a little more up to date and up to speed as far as what a concussion is, and therefore, if they do sustain one, maybe they're more apt to going to get evaluated. So it could be a good thing from that standpoint. Most TBIs, which is uncommon, are involving athletic activities, football, playground activities, basketball, soccer, etc. And like we mentioned before, because the majority of people in organized sports are from adolescent through college, it's not uncommon that we'll see the most sports recreation TBIs in the ER visits are in that age category, which isn't unheard of. But obviously, it can be from little Johnny falling off the jungle gym to motor vehicle accidents to something at work. So it is not just related to sports. But today in this topic itself, we're going to just really concentrate on the sports-related concussions. So the 6th International Conference started in Amsterdam. Initially, it was supposed to be in 10/20/20, but a thing called COVID happened. So it got delayed. It was originally supposed to be in Paris. So they delayed it a couple of years from that standpoint. They did involve a consensus panel of over 31 individuals from 9 countries. They also did include athletes this time. This is the first time they've done that. And they really made a good point to make sure that the methodology was ethical. Each individual had a conflict of interest completed. And the reason that they did that is because actually the symposium prior, the chairman, Paul McCrory from Australia, actually was found to plagiarize a few of his research articles after that last symposium. So they wanted to make sure that there wasn't any issues with that and make sure it was medically ethical. Each individual had certain sections that they researched, and then they came back and reviewed it. And if there was an 80% agreement among the individuals, then it was accepted in the consensus statement. If it wasn't, or it was a little below, they did make a mention of that, but it wouldn't be necessarily into the acceptance for the consensus statement. The way they wrote the article, they broke it down into different sections, so it's a little easier to read, divided into the R's, and you can read that on the slide, but we'll go over them individually. The biggest thing that has changed is that rest and exercise, especially from the previous symposiums, and we'll get into that as far as what that entails and how the changes come about. They also did add a retirement of athletes, which wasn't in before. They also refined some section, meaning that they included para sports or Paralympians or para athletics, as well as pediatrics. Like I said, they did really put an emphasis on pediatrics because there really was not really a good amount of literature in that. There still is a pretty low amount. So for future research, that's one of the main areas that they want to really delve into. Again, para sports are also becoming more popular with individuals. So that's also something that they wanted to talk about. They did define that, again, every meeting is going to be every 5 or 6 years. So the next one is tentatively in 2027. The place is to still be determined. So what actually is a concussion? And they wanted to make it uniform with the American College of Rehab Medicine, just so everybody's on the same page. Concussion is a brain injury. It's a traumatic brain injury induced by mechanical forces, usually a direct blow to the head, but it could also be to the face, the neck, or even to the body and then you have your body transmit impulsive forces up to the head so you can get this jarring effect. So it doesn't necessarily have to be a direct head-to-head collision. Pathophysiology wise, it's a shift in calcium and potassium. And then you see this drop in glucose where essentially the brain is being starved, so to speak. And I usually explain to people if they've never had a concussion, if you've ever fasted or missed a few meals, and you get that gnawing feeling, you get a headache, you get irritable, you sometimes get nauseous. Those are all similar type of symptoms that you get with a concussion. So just think about that. That's sort of what they feel about if you've ever sustained a concussion that's similar to it. The good thing is, especially with sports-related concussions, it does often resolve over a period of time in a stepwise process. So then it does return back to normal in a stepwise process and with recovery. Depends on the individual. Sometimes it can take longer. Sometimes you can have some issues, especially have pre-existing conditions, which can muddy the waters, which we'll get into a little bit later. But the good thing is majority of people do recover in a sequential fashion, and usually 9% of people within 2 to 6 weeks is usually the norm as far as recovery for concussion. This is just a depiction of exactly what can happen. You can have like a coup contre coup where you actually hit on the front, and as you guys know, that the brain is sort of surrounded by cerebral spinal fluid, so it's sort of sitting in a fluid type of material, so it can move around and bounce around. And so if you get hit in the front, then the brain can hit the back of the skull and then go back and forth and wobble. We're also finding in research, which is found especially down in Virginia Tech with Dr. Brolinson, who had sensors on their helmets with an X, Y, and Z axis, that actually the rotational movement, so if you get hit on the oblique side of the head, not a direct hit, that's actually showing some shearing forces, and that actually may be more effective or causing the concussion rather than a blunt force right head on. So you do have to make sure you look into that rotational type of movement as well. So what are some facts? Most concussions do not involve loss of consciousness. This was important initially just because way back when, 20 years ago, I'm sort of dating myself, but when I went through fellowship, they had a grading scale of grade 1, grade 2, grade 3 concussions. Obviously, it's been thrown out since then, but the way that they really graded it was based on the loss of consciousness. So if 90% of people don't have loss of consciousness with sports-related concussions, it's really hard to have this grading scale. So we threw those out a long time ago. So I do know if you speak to somebody and they talk about grading, a grade 2 concussion, we know that they're really not up to date, and you really need to make sure you educate that person. Many concussions are misdiagnosed or not diagnosed at all. We're trying to do a good service of education, and that's really the really most important thing with concussion is teaching people what they are and how to look out for what the signs and symptoms are, so you don't keep playing with a concussion. You don't have any drastic effects. Concussions don't grossly show up on CT or MRI, and when this first came out with the consensus statements, initially when someone had a concussion on a Friday night football game, they would go to the ER and they would immediately get a CAT scan of their head. Now the ER docs have learned, and we're teaching them too, that it's not necessary to necessarily get a CT. It's unwanted radiation for a child that you may not need, so you don't necessarily have to jump to doing advanced imaging. Obviously, there are some certain reasons for it. If people are going downhill, or if there's more concern for any bleeds, which can happen, then obviously you may not need to get a CAT scan. But with every day or every time you have sustain a sports-related concussion, you don't necessarily need to go to get a CAT scan. And that's been basically since 2001 with every convention statement that imaging holds little value. There are some newer studies that are showing DTI, which is a diffusion tensor imaging, which is this nice picture on the right, where it's actually working at the cellular level. CT and MRI, usually you're looking at the gross findings. You don't usually see that as far as an acute bleed or anything like that. But sometimes at the cellular level, you can see it's almost like a traffic jam or a gaper delay, where the molecules just aren't moving through the neurons as quickly as they should, and therefore you get some irritation there. So sometimes you can see that light up on that. Other research evaluated imaging is a PET scan or functional MRI, where you're doing an MRI while you're doing some sort of test. You can see things light up in different areas. So you do have to have some sort of concussion event. You can't just wake up and say I had a concussion if nothing ever happened. Something has to occur to cause that. And then you end up having signs and symptoms. And what we're finding is the number of symptoms and the severity of symptoms really suggest a longer recovery. So if someone comes in and they have this Likert symptom score, which I'll show you is basically 22 symptoms and grade them from 0 to 6 and how you're feeling. If they've up in their 90s, they have they're wearing sunglasses, the lights are off, and they have other pre-existing conditions, and I know that it may take longer for them to recover versus if someone recovered fairly quickly after the Friday night, and I see them on Monday and they're doing pretty well. There is no set recovery time. The Amsterdam conference, they said average adolescents about a 1 month for recovery, and again, it's usually about 2 to 6 weeks is usually the norm, give or take. Some people more, some people less. But the biggest thing that we've brought up is that mental health and pre-injury history, such as migraines, ADD, ADHD, can increase risk symptoms for longer recovery for over a month. So you do have to take that into account. And that's why we're really trying to tease things out when people come into the office. If they do have any prior history of migraines or prior history of any mental illness, it's really something you want to look into. You also want to find out for the family history, just because they may not have been diagnosed with migraines or may have been not diagnosed with anxiety, depression, but after you sustain a concussion, then sometimes that can come to the surface a little sooner. So you may be diagnosed a little earlier than you would have been if you didn't have a concussion. We do find that there is a cumulative effect with multiple concussions where the threshold can get lowered. Doesn't mean that 3 strikes and you're out for athletics, but we can get into that a little bit later. But it does require the brain to heal, and it's again with concussion, especially in the adolescent, it goes beyond the playing field. It can really change everything in their everyday activity. As far as in school, seeing their friends, and just not involved having activities that just may really affect them. So you really can put a damper on them, but it really can turn their world upside down. So you really want to try to make sure to educate them, try not to make it doom and gloom, make sure that people realize that they will get better. It's just a matter of time, and sometimes that can help. As you know, when looking at an athlete, especially a teenager, it's really hard sometimes to read how they're feeling. They may look the same regardless if they're angry, irritable, happy. They just don't say much at all sometimes. So sometimes you really want to try to tease things out, make sure you get a good history, and find out what's really going on. The more tools you have, the better it is, especially for those type of athletes. So you want to ask them about, coaches, ask their parents. If you're on the field, you can see actually ask the other teammates, any other observations or teachers. So when we have someone come in, we often have them call our athletic trainer as one of our liaisons, and we can get a better history of as far as what's going on. And that helps us once we see them in the office. So some immediate signs you may see: confusion, deer in the headlights, glassy eyed. They may have headaches, nausea, something that you can't really miss once you have that type of issue. There may be some issues where it may be a mild minor student athlete, and then all of a sudden, because of the concussion, he changes his emotion. He starts crying on the sidelines, or he starts being real irritable, starts cursing, without any sense of why he's doing that. And it's just out of his norm. So we know that maybe something's going on for that. So you really want to look into it. And that's when you really get involved with the athletic trainers, because they know the students a lot more than the physicians do, because we don't see them every day. So, if there's someone that's, really acting abnormal, then sometimes we may need to evaluate them and check them out. Other physical symptoms: headache is the most common, loss of balance. And we do a lot of balance issues now with concussion management, sleeping issues, feeling foggy, dizziness, fatigue, all the things that you may see. And sometimes you may not see them until afterwards, if they're in school and having trouble. But the immediate symptoms are some things you can see and get checked out. Some cognitive issues, confusion, slower rate of processing, slower reaction time, difficulty reading or concentrating. So you really want to look into that, especially if they've had issues over the next couple of days after the concussion. And then emotional irritability, anxiety, depression, anxiety, saddened. And again, you really have to delve into this and tease that out, just because a normal teenager or someone that's going through a breakup or have some issues with their friends, it can almost be these type of emotional symptoms too. So you really want to make sure, is it from the concussion or is it from something else? So you really want to get a good history. With prevention, we do try to find some things to try to slow down any risk of concussion. So we've made some rule changes, equipment, training strategies, and then we've also had some laws and protocols that's been enacted in each state. So we'll get into those. Some rule modifications. Ice hockey, there's no body checks, or we're not supposed to, at least until after age 12. And we've actually found a reduction in concussions about 59% because of that. Especially the lower levels and the midget hockey and the little guys. We're trying to avoid that. Also, reduce collision contact practice in football. And this is actually coming from the NFL, and then it's going downhill from there, just because it's a trickle down effect. As you know, that for people that are Eagles fans, they've been harping on the last couple of years where the practices aren't as physical as they used to be, or they're not hitting as much, and they're just trying to avoid multiple hits. We're also finding that kids starting flag football and then not really starting regular football until age 12, 13, so you can avoid 5 or 6 years of getting hit at that young age. And as you know, if you have a football player that's really young, their head is really a little bit bigger than their body. It's almost like a bobblehead. So they can't really support their head as much. So sometimes it can be more increased risk for that. So if we try to, have them learn about football with, flag football, which has been a great asset and a great addition. It's become very popular. I think it's actually even including into the Olympics next time around in LA. But people are definitely starting to go to that route and learning the rules of football before really going into playing contact or tackle. The other thing is that in soccer, there's no heading until age 11 or 12. If you do head the ball before that, you do sustain a penalty, so you can't continue to play, and the ref calls a whistle. So it's something that we try to avoid. And this is just going because they may not be able to head the ball yet. Their neck muscles may not be strong enough to support this, and they just may not have the coordination for that yet. So true or false, helmets prevent concussions. No, I can't see anybody's hands. But this is often something we ask people, and it's actually false. There's no real way a helmet's going to prevent a concussion or prevent skull fractures or prevent other issues, loss of teeth and stuff like that. But I usually explain the analogy. If you think of your brain as like a yolk in an egg, it's surrounded by fluid and it swishes around, and the shell is your skull. If you bubble wrap that egg and you have an egg toss and you throw the egg around, the yolk is still going to swish around. It's going to hit the inside part of the skull, but it's just not going to crack the egg as easily. So it's sort of a good analogy that people understand. But it can, reduce the forces a little bit, but it doesn't prevent true concussions. There is a study down in Florida that just came out where they require women's lacrosse players to have helmets, and they have shown there was a decrease in concussions from those students. We're still seeing if it's out there as far as the data hasn't come through completely with other sports, if it's really a true effect or is just individual with lacrosse. There's always things that come out now with headbands or other headgear used for soccer. It hasn't shown any issue with prevention. We do show that mouth guards can be associated with reduction with loss of teeth and some issues as far as reducing the blow. So that may be a factor. Some people have also come up to me, and there's newer things called the Q collar, which is you'll see people with in football, lacrosse wearing it, where they put it on their neck, and it actually pushes like a little pulse or force to increase the jugular vein return up to the head, so it sort of gives more blood into that area, so you have a little more cushion is the goal of that. It's still the data is still not out yet for that. We'll see what happens. It costs about $200 to buy that, so it's a little expensive. And then again, we always see one of these things come out and then it sort of falls by the wayside, but we'll see if it holds stick and it sticks. If it's the evidence is showing that it's positive, and then we can move forward with it. Other thing, reduction, training strategies. There's been a study with neuromuscular training 3 times a week and has reduced it in rugby. Laws and protocols, we find that if you're concerned for a concussion or you think that someone's sustained concussion, they have mandatory removal. They're not allowed to go back to playing if you think they just sustained a concussion. They can't go back until they have clearance from a healthcare provider with a return to play protocol. Again, we also, with the protocols, we want to educate the coaches, players, and parents. Often have to sign a policy before each season, saying that they read a protocol with each school policy, and that they understood what a concussion is and what it entails. Just a plug for the Brain Injury Alliance in Jersey. We did have a big factor in this back in 2010, where we did sign a concussion law. We were the 7th state in the nation to develop a concussion law. Now all 50 states do have a concussion law, but we were way ahead of the curve in the 7th one, and as far as in the nation. And again, Brain Injury Alliance has done a great service with education. We have a whole sports concussion committee that we meet with regularly, and we try to educate and teach and make sure that people are aware of what concussions are and give them updates. So with the laws, again, anytime you're concerned, you want to remove the athlete and then make sure you have a proper evaluation. There have been some rule changes, especially even up in the higher levels with the NHL. If someone's sustained a concussion, they have to go to the locker room to get evaluated. You see now, even with other sports, they're putting that tent up in the on the sidelines is not ideal because there's still very loud noises and stuff like that. But at least you can get away from the fans and with people seeing what's going on, and you can sort of try to do a further evaluation if you can. Education is still number one. You need to make sure everybody's on the same page: coaches, parents, athletes, healthcare personnel. You want to make sure that people understand what a concussion is, what the symptoms are, and then how to treat it. But like I said, it can go above just the playing field: academics, social relationships. The individuals that play sports, they often their friends are on their team. So if you sustain a concussion, then they can't play, then they can't sometimes go to practice, and then they're not hanging out with their friends. And sort of the world seems like it's turned upside down. Sometimes you get behavior changes, emotional changes. Academic stresses can also be a factor. So you definitely want to make sure you incorporate that into return to learn, return to play, and making sure that they're able to go back safely with all their venues and all their activities. So how do you evaluate concussions? First, you're on the sidelines. Biggest thing is you have a neurocognitive and balanced baseline if you can, and then you can compare it to that. If there's any changes, you do a medical evaluation, and you can also do a neuropsych evaluation as well. But it incorporates all different disciplines. On the sideline evaluation, we first did it's called SCAT, which is a sport concussion assessment tool, and they did update this. And it's monitored. It's meant for people for the first 72 hours for your acute evaluation. With this last symposium, they did incorporate the sport concussion office assessment tool, which is a little more involved and a little more in depth with physical exam and assessment. Obviously, any red flags, you have to make sure you don't go down this road. And if so, sometimes you do have to send them to the emergency room for any worsening issues. So sometimes there's the MATA questions, symptom severity score, SAC questions, which we all know about. And then the coordination of value and balance error scoring system and cognitive assessment. Again, this is more for the acute evaluation, usually within the first 72 hours. And then thereafter, we go into a more in-depth exam. This is just a quick review of what the picture is. And you can actually get this online if you go to the British Journal of Sports Medicine, the 6 concussions symposium, and then you go to the supplement section. They actually have this printed out. And this is really good for uniformity. So if I talk to somebody across the country or, athletic trainer, he said he did a SCAT and this is what happened and this is what the score is. So we know what's going on. This is the Likert symptom score, where you have an assessment of all these symptoms. You grade them from 0 to 6, and then you count how much you have. That's your symptom score. This is the SAC questions, or what month is it, date, etc. Then we do some memory, where we name 10 different names or items, and you have to try to repeat them. We do numbers where you go 3, 4, and 5, and you have to try to repeat them backwards. Sometimes We do that while they're doing a tandem gait. So sometimes we find that it may be too easy if you're just doing the numbers. You do also have to look into each individual, because some people have difficulty regardless, or if they have ADD or if they have learning disabilities, so they may not be able to do that. So you have to take that into account. This is the modified balance area scoring system, where you have double leg stance and two tandem stance on their non-dominant leg, and you count how many times they fall over or put their foot down, and that's as far as counting how many issues they have for the balance. This is good if you have particularly if you have a baseline. So some of the schools have been doing this prior, so you can compare it and see if there's any differences. Obviously, if they have any ankle issues or other problems, they may have problems with their balance regardless. So you do have to take that into account. This is that dual task gait that I talked about. Then afterwards, you go back to recall, ask them how many words they remember. And then there's a cognitive score, and you can add them up, and then you can determine what they are and how they do it. And you can do this sequentially to see how they do, if they improve over time when you're looking at them over the next day or two. The sport concussion office assessment tool is a little more in depth, as we talked about. With this last symposium, we also did a child scat and child scope, which is ages 8 to 12. So they're asking the kids a little more questions at their level, so they don't know, so they understand what the words are and how to go through an exam. Again, it also includes anxiety, depression, sleep screens, orthostatics, cervical assessment, and then the neuro exam, which is really important. And we're seeing a lot of vestibular issues, so that's also paramount in your exam. Again, this is something you ask the kid versus an adult. If your neck hurts versus a headache, and sometimes they don't understand what dizziness is or drowsiness, so you just simplify that a little bit. And then you can ask the parents the same thing and see if there's any differences between the two. Again, this is just a depiction of this, so I'll go through that but you can get this online and read up on your own about it. So the first thing is you do a cervical spine assessment, making sure the range of motion is not hindered. Obviously, make sure there's no bony issues, for they may have more serious injuries because they still can have a spinal injury. You may have to board them if you have to. So again, you want to make sure you look into that if they have any numbness or tingling or any more pressing issues to treat. Cranial nerves and orthoneurologic findings as well are important to look into. And then we also do this modified vestibular motor screening, or VOMS, what we see. And what smooth pursuits is sort of the T, where you go back and forth, up and down. You have them follow your eyes, follow their finger, and make sure that they have smooth pursuits and no issues with that as far as any jittery eyes or going back and forth. Saccades is where you put two hands up in front and you go back and forth, your eyes back and forth 10 times very quickly, and make sure that they don't have any issues with that. Vestibular reflex, sort of like a metronome, where you put your hand or thumb out in front, and then you're going to turn your head back and forth at 180 beats a minute and see if there's any changes or any causes issues with vestibular issues or dizziness or problems with their vision. And then the vision motor sensory test is where you put your thumb out in front of you, and then you actually follow the thumb back and forth, where you move the head while you're following the thumb, and see if there's any issues with that as well. Once you go through all those tests, then you can see if there's any referrals that be needed. And again, this is just more to make it a little more uniform, so you can talk to somebody across the country and you understand what they're doing, what they went through as far as their examination. Just briefly touch about some baseline testing. There's a computer neuropsych test. When we mostly use as an impact test. We're sort of using this less and less as much. When it first came out, we were using it as soon as some individual had sustained a concussion. We're finding that obviously that's not really a great idea, because if they're very symptomatic and they have a lot of issues, to take a 25-minute computer test wouldn't be worthwhile, and your scores are not going to be very good. But if you do have it, as they improve and their symptoms get better, we can use this as a tool to see if there's any other cognitive issues and make sure that they're back to their baseline. But again, we're not putting as much emphasis on this as we used to. The biggest thing is really how they're doing academically, their physical neurological exam, and other symptoms that they're going through. Biggest change that we've been seeing is that rest and exercise. Initially, back in the day, we used to have them cocoon, stay out for a week, and then go back to school thereafter. We don't do that anymore. I don't really remember the last time I really kept people out for an extended period of time. We try to get them back as quickly as we can, in a safe manner where we do academic accommodations, maybe half a day or, take breaks as needed, hold off on exams, print out the PowerPoints so they're not looking at a screen all day. So there's definitely modifications that you can use. And we're trying to find that if you incorporate them back to as much as they can as a normal teenager, then they don't dwell on the symptoms they're having. They don't have more anxiety. And sometimes that can help with recovery a little quicker. The other thing we're also finding is that this light aerobic activity and advanced with sub-symptom threshold, we're moving them forward a little bit more. This is brought out after Dr. Letty in Buffalo, but we're now moving this forward with even return to play, where if you start return to play with non-impact activities, as long as it doesn't go above a 2-point threshold. So if they have a headache of a 3, you don't want to have them to go to a headache of a 5. But you can start with them with some biking or elliptical, because we're finding that also can be helpful just because they're used to being active. And if they don't be active and just sit around like a couch potato, then sometimes it can prolong some issues. So the fact that, they want to be active and they want to stay a little bit active, it can be helpful. So we are starting to actually move them along a little bit sooner, where even you can start doing, the first couple steps of non-impact before that. And then you can complete the return to play protocol later on. You can't go to any impact return to play, which we'll get into, until they're symptom free. They're back to full academics. But we are starting to do this a little earlier, and we're finding that it can help with recovery. This is another study that, again, we're finding that it's not for athletes. If they start doing some activities, release natural endorphins, can help make them feel better and helps with cerebral regulation. We do find that we want to try to stay away from a lot of screen time, especially the first 24 or 48 hours if we can. So if they sustain injury on Friday night, we really want to try to limit their activity on an iPad or phone or video games for that weekend in particular. And this is, again, cognitive rest, physical rest, and it's different for each person, but we're all trying to incorporate that a little bit more, so where we start doing some activities, not just have them do nothing and just stay home or be a couch potato. Obviously, activities to avoid: video games, driving, going to concerts and movies, amusement parks, which is funny because I've always had people going on trips and they say, well, I told them not to go and do any video games, but I did go to Great Adventure the other day. And, obviously that's not a good thing either, just because you're jarring and you're going back and forth on rides, and just a lot of stimuli can affect you. Sometimes we do try to limit the screen time so we can print out, PowerPoints. It's difficult now with schools. Everyone's on an iPad or a Chromebook, so it's difficult for learning from that standpoint, especially if they're there all day. So when do we refer? A lot of times depends on how comfortable you are, but if they do have persisting symptoms over 4 weeks, then you sometimes have to involve multidisciplines, where you may need physical therapy, like vestibular therapy, ocular therapy, neuropsychologists may be involved, psychiatry, especially if they have mental pre-existing conditions. Obviously, the ATCs are paramount with recovery and checking in everyone on a daily basis, sometimes cognitive therapy. So it's a slew of disciplines that can help. One person doesn't do everything. You have to make sure you have everybody help you out. We are finding with this last symposium, if you do have some dizziness and balance issues, we're having a shorter leash as far as getting them into vestibular therapy. So if they do have persistent headaches or issues with that, we do get them in a little sooner, and we're finding that it has been helpful. It's also just helpful just because they're doing something, and so they feel like it's helpful just because they're being more active, and it feels like they're not just waiting time to heal itself. So sometimes that can be helpful in itself. Again, it's a team effort. Everybody's involved. It's not just a one-stop shop. So you really want to make sure that you know who's around your community, who can help and can help with the individuals getting back safely. Why is it important to return to the classroom? We talk about the biopsychosocial model, the medical school and undergrad, even with the athletic trainers that we work with. So they need to see friends, engage with others. They need a social outlet. Otherwise, they start dwelling on things. Again, you can't go from a cocoon to a classroom. You want to go in a stepwise process, and that can sometimes increase depression issues if they are staying away from school and not hanging out with friends. So again, reduce assignments. Give additional time. Sometimes hold off on exams. Written directions versus just on the PowerPoints. If they do have more issues, then sometimes you do have to involve, setting up a 504 plan or IP plan. Eventually, sometimes to take breaks as needed. But again, we do try to get them back just some schooling at least with some modifications, so they're not just staying home and not doing anything. And here's just actually, this is the first time they did actually a little stepwise protocol for return to learn, where they first do some reading and some screen time, some work that they do at 5 to 15 minutes at a time, and then if they're improving, then you can increase some homework activities, get back to partial school, and then full school. There was a study recently, Margot Putikin in Princeton, where he said 93% of athletes, this is more the college level, will return to learn without support by 10 to 14 days. So again, even though it seems like it's a long time, it's really not over the long haul. This is just a little change of the graduated return to play protocol. As you see, the steps 1, 2, and 3 are non-impact activities. And we're finding that especially 2A, 2B, where we're increasing the heart rate a little bit, as long as they're not in that sub-threshold and not increasing their symptoms twofold from like a 3 to a 5, for example, then we're okay to continue and increase that. The way you get a maximum heart rate, if you take 220 minus their age, that's sort of the maximum heart rate. So you take 55% of that, and that's what you want to get to that goal if you can. And then 2B is 70% of the maximum heart rate. If they're still doing well, then you can keep increasing it to sport-specific activities. And then the 4, 5, and 6, again, you're not able to really allow them to move on until you get reevaluated, make sure that they're symptom-free, not have any issues with that, academics, make sure their physical neurological exam is well maintained, and then you can move on and complete that return to play protocol. Why is it important to do this return to play protocol? You don't want to jump in too soon, too quickly, because then you can have some prolonged recovery, especially if the symptoms come back on you. It can have cumulative effects of multiple concussions. Obviously, if you're not completely resolved from the first one and have another one, then that's when the bad stuff can happen. We always hear about the dreaded second impact syndrome. We'll have a couple slides in the future for this, exactly what this entails, but you have this post-concussive syndrome, which can take a lot longer to recover. Again, fortunately, about 90% of people do recover in a quick time frame, but you do have this 10% that sometimes do involve other disciplines and may take a little longer to recover. The common symptoms include fatigue, headache, balance issues, a big factor. Again, if they have any pre-existing conditions, that's really the thing that we really want to try to tease out and make sure that we're not missing those, because if we cheat those, then a lot of times the other stuff gets better. Second impact syndrome, still a pretty rare entity, but it's still out there. You have to have a witness first impact and documented ongoing symptoms, and you have another second impact on that same time when they're not improving, and then you end up seeing cerebral swelling without a hematoma or any true issues from that. You change of autoregulation and cerebral swelling. There was actually a good documentary on PBS several years back. Often it can be deadly, but sometimes if not, you can have a significant brain injury, and sometimes it can be permanent, not recover. So this is something we really want to try to avoid. Unfortunately, this is what you hear about every year across the country, where you have a tragic story, what happens, and then that's unfortunate for individuals, but then that's how things sometimes change with laws and protocols. If something tragic has to happen, so we're trying to prevent that beforehand, so we don't have to keep having these stories. That's pretty sad. Some good things that are doom and gloom as far as in the studies with the literature has found that amateur athletes are not an increased risk for depression, suicide in adulthood. This goes along with when CTE came out, which I will talk about in a second. But finding that any amateur athlete that doesn't go into professionals do not actually see risk for cognitive impairment or neurodegenerative disease at a later time. They're usually doing well, and they can have no issues later on. We do find that some professional football players or soccer players, just because they continue playing, they have constant hitting that's longer for a period of time, and they can have these sub-threshold hits. And sometimes we're finding that with some of those individuals, they are starting to get some issues later on, which can have some greater mortality. The issue with this, however, we do need to get more studies, is because it's a subset and a small cohort. It's individuals that again just play in that football or soccer realm where they're constantly getting hit, but we're also finding, are some of these individuals, do they also have pre-existing conditions beforehand, and maybe they are at more risk for sustaining this issue over CTE because they have other existing conditions prior. CTE, what you find about is chronic traumatic encephalopathy. They did rename it to neuropathologic changes. It is post-mortem, so you can't determine if you have CTE unless you do take a sample of the brain after their death. And this is from people giving their brains to science up in Boston. There's a study years ago that basically put this out where they came out with 99% of football players that gave their brain had CTE. It doesn't mean that 99% of people that play football have it. Just those individuals that had symptoms and their families were concerned that something was going on there, then they gave their brain the signs. So it's a sort of bias subset just because those individuals already having symptoms that may involve CTE. So it's not, again, every single person that plays football is going to get this. It's few and far between, really. We did involve a diagnosis of traumatic encephalopathy syndrome, which was named in 2021, which is this people that may think that may have CTE later on after postmortem, but they may end up having these issues. We call this the traumatic encephalopathy syndrome. This is also new to the symposium that we did involved, which is retirement. It's always a hard thing to come to terms with individuals. I'm actually finding when I do have this tough talk, it's really more that the parents you have to really deal with versus the kids. A lot of times, a lot of the kids are very mature and they understand this once they get to this point. But you want to make sure involve them in other alternatives. You can still play sports, just may not be able to play that particular sport. Or if you want to be involved with sports, I have a lot of them individuals going into coaching or other issues with that. So you still can be involved with that activity, but just not at that level with the impact. But it's definitely something that you have to think about. You want to involve the athlete as much as the parents and the coaches and everybody else in their circle. Finally, for refining, we did talk about para sports. Again, if you can have a baseline, it's more important just because these individuals have CNS injuries or may require more time to recover, and the return to play may be tailored to their individual status. Again, pediatrics, we did talk about a child SCAT, child SCOAT. We're using more prevention efforts, and we're trying to increase the research for that younger population. So in the next symposium, 2027, hopefully there will be a lot more research that we can look into for that younger population. Other research that we're involving with is genetic phenotyping, ApoE4 gene, can be risk factors, balance testing, biomechanical markers. For blast injuries, we are finding that there's proteins in the blood. At the lower level, as far as the sports concussion, we are not at that level yet, but hopefully as we get more specific, sometimes you can just have a blood test and you can determine if someone sustained a head injury or not, but eventually may be out there. Again, we have seen sensor helmets with X, Y, and Z axis, and actually each hit, you can determine how much the G-force is, and sometimes there's some protocol where, if it's above this certain G-force, then sometimes you may look into it because that may be a problem where they may sustain a concussion at that point. And then obviously rule changes are really important to try to avoid future problems. They did ask 340 of the attendees at the symposium what other future research, and the potential long-term effects is a big factor. Recovery, persisting symptoms, and detection are the main ones that they talked about. This is just a study that we did in our offices where we determined that if gender, age, and sport played a useful predictor, where we had first-time concussions ages 12 to 18, and if male versus female took longer to recover from. When we looked at it initially, back then, there was 110 males, 110 females, and males average 11 days before recovery versus females average 28 days. So we looked into that. Was there a reason? Was it multifactorial? Is it hormonal? Is it biomechanical? Are their neck muscles stronger than others? Or is it just psychosocial culture? Are females just more prone to being more truthful to telling if they still have symptoms versus hiding the symptoms with the males? Or is it biological? Is there an innate predisposition where some individuals just may not get concussions as much as other ones? So it's something to look into. We then did another update several years later after we changed some of the protocols, and we didn't have the doom and gloom. We really looked into pre-existing conditions, and we're finding that the pre-existing conditions, if we treat those, then the recovery can help a lot better. Again, we try to make sure that people understand that people do get better. It's not doom and gloom. And then we do find that actually has reduced the return to becoming asymptomatic a lot quicker for those individuals. So it is a positive. So as we see the protocols change, we also can see that the recovery can get better too. And final, there are some concussion training courses that you may need. CDC has done a great job with the Heads Up concussion program. You can look this up online. They do a lot of pamphlets and handouts that you can give and have in your training room or in your offices. But it can be helpful for managing return to play, and it's good for the education. Other things are concussion-wise. Most are free. Some have a little nominal fee, but some individuals you do actually have to take some sort of course and have some sort of certificate, so you can hang your hat on that. It's not the greatest thing, but at least they've shown that you did update this. You do get CUs for this talk. This would probably be good for a training course, but unfortunately I can't give you a certificate for that, but you can get a CEU for it at least. So in conclusion, concussions are underreported. Again, education is paramount, and we're doing a great service. We're still moving forward. We still have a lot to learn about concussions, but we are at least getting that out there to understand what people understand what they are. It's not just you didn't get your bell rung and that's it. It's something that may be more concerning. A multidisciplinary approach is very important, especially if the individuals are having some factors and it's a prolonged recovery. Return to learn is just as important, if not more important, than return to play. And then again, research is really paramount, just because things can change. From what we did 20 years ago when I started versus now, it's done 150, 180 degree flip, and things have really just changed as a paradigm shift. So if you can remember anything, when in doubt, sit them out. You only have one brain, protect it. These are some resources that we talked about. That Brain Injuries Alliance of New Jersey has done, as well as CDC. This is just a plug. We do have a annual brain injury walk for South Jersey individuals. It'll be on September 28th at Laurel Acres in Mount Laurel, but we also do have one in Paramus and Bradley Beach that you can sign up for. If you can't go, obviously you can also donate too, but we would love to have you out there. It's a great event every year. These are some references. This is my puppy Augie. He's now 1 year old. He's about 70 pounds now, so he's much bigger, but my kids like this picture, so I wanted to put it on.
Well, thank you so much.
Yeah, sure.
Thank you so much for that most informative presentation. We do have a couple of minutes for some questions, so I'll take a few questions. It looks like we have a couple of questions about the Guardian caps for football helmets. Could you weigh in about that?
Yeah, I mean, you see those, for individual, especially in preseason with the football players. Again, it's something that really is just to make sure people understand that, you want to try not to hit them as much during those practices. It's almost like, having the quarterback wear the red jersey. Does it really prevent concussions? Not really, but it's really making sure that people, cut back on their hitting as much from that standpoint. So I think it's more psychological than really actually helping physically.
And then we have another question that he stated, what is considered to be statistically significant with regard to dual task tandem gait versus tandem gait time measurement and or number of errors?
So when you do the dual task, it's, you're doing subtraction of like sevens while you're walking one foot in front of the other. Again, if you can have a baseline, that's ideal, because then you can compare it to individuals and see if there's any changes there. But if they start having this and they have some trouble, or if they fall over, if they have difficulty with the subtraction, then sometimes it can be an issue where you have to look into it further.
Great. And then someone else asked, how close are we to using blood tests and blood markers to help determine concussions?
Yeah, so we do have it for blast injuries, which is more obviously more concerning and more serious, where you're thinking about getting other significant testing like CAT scans and stuff like that. But it was initially in the military that they started, but we're not there yet for concussion in sport per se. I think it's definitely going to be coming down the pipeline eventually. So who knows if next time I give a talk in a couple of years, if it's going to be something that we can think about. But it will be in the future somehow at some point, just because we're getting sensitivity with protein leakage into the blood and seeing which ones may be affected. So I think it's definitely going to be coming in the near future.
Great. And then someone else asked, can you suggest any supplements during the recovery period? Do you have any suggestions for that?
Yeah, I mean, there are some other studies, some are anecdotal a little bit, but we've actually been transitioning where some people with some vitamin supplements with people with migraines, where we've been using magnesium fish oil, B2, and that's been somewhat helpful for headaches for those individuals. So sometimes you can use those for concussion individuals. Again, it's not, the side effects are few and far between, if that, because they're really more just vitamins, so it could be helpful for those individuals. Just have to make sure if you do have them take those, especially the B2, sometimes it can make your urine a little different colored. So just let them know about that. But there are some things we do. Sometimes, helpful for sleep. We've been using sleep aids, but also melatonin sometimes can be helpful. So those are some things you can try too.
Okay, great. Thank you. And someone else asked, were you able to read a JAMA publication from last August on CTE being present in young contact sport athletes, or do you have any comment about that specific study?
What was it again? Say it again.
They said there was a JAMA publication from last August on CTE being present in young contact sport athletes.
Yeah, I mean, it's like I said, it can be out there, but usually we see the CTE, after extended period of time, again, more seeing the professionals with, years and years of being hit over years in time. And then you can actually see some of the changes that they had before they pass away. But there can be some outliers, especially the younger population. But like I said, you really, want to look into those individuals if they've had pre-existing conditions already, versus, truly CTE versus something else.
Okay, great. Thank you. And we have some comments saying excellent talk. Thank you so much. And so in conclusion, it looks like we only have a minute left. So thank you again, Dave, Dr. Gelt, for sharing your experience with us today. If your question was not answered today, attendees can email me at kmyers@bianj.org, and I will try to have Dr. Gelt answer it. One final reminder to please complete the post-webinar survey. The link can be found in the chat. Let me just put it in there for you. That is a link to the survey in the chat.
If I could,
Whoops,
sorry, go ahead. I don't want to cut you off first.
No, no worries.
I was just say, if I could just have one other plug, just for education, for any athletic trainers still online, if they need CEUs, we actually do have our annual athletic training symposium in November. So you can go to Cooper and sign up for that if you want. Be November 12th.
Thank you. So that is November 12th. And so I put this link to the survey in the chat for the post-webinar survey, but there will be a different survey going to athletic trainers after the webinar. You'll be receiving an email. That's your CEU survey. So please be sure to complete that if you're looking for CEUs as well. And thank you again for attending. Thanks everyone for your time today. Thank you again, Dr. Gelt, for presenting. And we hope to see everyone at the September 24th webinar. So that concludes today's webinar.
Thank you, everybody. Have a good day.